Hi, I'm Dr. Mitchell Humphreys, Chair and Professor from the Department of Urology at Mayo Clinic in Arizona. One of the newer ideologies around prostate cancer is focal therapy for prostate cancer. So part of the reason in the past we haven't been able to treat prostate cancer focally is usually prostate cancer happens in multiple areas of the prostate. We were limited by imaging technology where we couldn't always find the areas of the cancer and we couldn't separate normal prostate from cancerous prostate. Now with newer advanced imaging techniques, with risk predictive models, stratifications, and genomics, we can now identify which parts of the prostate may have cancer and which ones need to be treated. With some of these new focal treatments, we're able to treat just those areas of the prostate that may have disease. The advantage of this is the outcomes are very good from a functional standpoint. You don't risk incontinence, you do not risk erectile dysfunction, and it treats the cancer. However, with these treatments, there is some cost that comes to it because the cancer does come back, and about 30% of individuals that have focal treatment end up needing additional treatment somewhere down the road. Not all prostate cancers are eligible for focal treatment. It depends on the disease, the extent of the disease, the Gleason score of the disease, and there is a very regimented follow-up pattern after focal therapy because it can come back. That may mean biopsies or imaging some point down the future. However, focal therapy is a very intriguing and interesting new modality for prostate cancer. We've been seeing it in other organs and other malignancies with a great deal of success. There's promise for what happens today could be meaningful some point in the future in treating your prostate cancer. If this is something you want to know more about, please see the attached references. So when we talk about focal therapy, there are many modalities that you can use to focally treat the prostate. You can use lasers to destroy just the parts of the prostate and the prostate cancer. You can use something called cryotherapy, which destroys the tissue through freezing and cooling those cells below 40 degrees centigrade. Or you can use something called HIFU, or high intensity focused ultrasound. High-intensity focused ultrasound is probably the most common modality of focal therapy. There are new systems out there that are available with robotic precision and focal therapy. What that means for you, the patient, is with that robotic precision is they're reproducible. They can merge with your imaging. So if you've had a test such as a multiparametric MRI that identifies the prostate cancer, it will interface with the robot so just that area is precisely treated. The additional thing about focal therapy is many of them can be repeated even if the cancer comes back. So specifically with robotic focal HIFU, what one should expect is that they need to have a prep beforehand, and that would include antibiotics as well as a bowel prep, because what it includes is when the patient or you go under anesthesia, you don't necessarily have to be paralyzed, but it is general anesthesia or spinal anesthesia, but spinal doesn't work as well because it induces some movement, and it's important that you stay perfectly still during the procedure. What the procedure entails is the probe that goes into the rectum. That's the robotic probe. It's monitored at a control desk, and the surgeon then very precisely creates the little lesions within the prostate to destroy the lesions of the prostate cancer. Afterwards, you have a Foley catheter in your bladder anywhere from 3 to 7 days, because that heat energy or the HIFU creates lesions within the prostate that cause temporary prostate swelling. Soon thereafter, though, that swelling goes away and people are able to urinate without problems and get back to their normal activity within 1 to 2 weeks. Typically, we put patients on something called Flomax or an alpha blocker to help relax the prostate during that time of healing. It will take 4 to 6 weeks, and you may actually notice that your urination gets better while the cells destroyed by the HIFU get removed by your body and your own immune system to make things better for you. So when we talk about focal HIFU, the thing is patients don't experience much pain afterwards. They may have some irritation from the Foley catheter. They're on antibiotics for a few days, but no actual incisions are made into the body. There's not much in terms of pain, and the recovery is very fast and patients tolerate it very well. The advantage of this is it's an easy outpatient procedure. You don't have to stay in the hospital. The downside is you have to have a Foley catheter in for 3 to 7 days, and there is a high retreatment rate, approximately 30% over the next 5 to 7 years. The long-term data, though, with using these merged systems with image-guided, precise robotic HIFU has been pretty encouraging. The newer systems on the market today add a lot of control and precision to the procedure, making it ideal for this type of treatment for your prostate cancer. But again, not all prostate cancers are eligible. It's really meant for those men with intermediate disease or low-grade disease who have focal lesions that can easily be identified, who really care about maximizing their current functional outcome, willing to take a higher risk of cancer coming back somewhere down the road. Doesn't mean that it can't be treated when it comes back, but it is certainly more of a risk with this type of treatment. It is still considered experimental because the long-term data on it is mostly come out of Europe. We do not have long-term data on the robotic HIFU, and we do not have 10-year data on that other than some very early preliminary reports. However, from those preliminary reports, the technology and the technique have changed considerably based on what we've learned. So you have to think carefully, and is this the right thing for you and for your disease? Because again, you can think of it as maximizing your functional outcome with minimal risk of incontinence or erectile dysfunction, coupled with a higher risk of the cancer coming back somewhere down the road.